Assalamu alaikum. Bismillahirrahmanirrahim. We are going to discuss a very important but a lengthy topic, and the things which we come across during anesthesia. These are the complications of general and regional anesthesia. The complication ranges from minor complication to moderate to severe and then to the lethal complication. Like there may be minor injury during anesthesia and surgery, but there may be death of the patient. So complications which leading to harm or injury, but there is no death, these are called as morbidity during anesthesia. And if a person dies during anesthesia, it's called as mortality. So there is a incidence of complication is almost 9 to 10%. Means out of 100, 9 to 10% of the patient may go into the complication. For that, important thing is that you need to identify few patient according to the type of the surgery, according to the body and weight of the patient, the nature of the surgery, as well as the age of the patient. For example, if we go for the prolonged surgery, even if patient is not having any comorbidity means illness other than the illness for which patient is came for the surgical procedure. So prolonged surgery means at least surgery for 3 hours or above duration. Means more than 2 hours duration surgery can be labeled as a prolonged surgery. And obviously once the surgery is prolonged, there will be the more stress to the body systems, more release of catecholamines from the body, as well as you need anesthesia drugs, exposure to the anesthesia drugs for a larger doses or continuation of the drugs, as well as exposure to the operation theater environment, that is hypothermia. Again, it has got its own consequences. We will go in brief in next slides about hypothermia do during the surgery. There may be blood loss if surgery is prolonged. Obviously, there is prolonged surgery, there will be delayed recovery. Then morbidly obese. Obese patient is the patient who are normal, more than the normal body weight. The patient is labeled as obese, and obesity or body weight is denoted by height, weight in kgs divided by height in meter square. That is called as body mass index. Ideally, one should be less than 25 body mass index. Is about 30, it's a obesity, and if it's about 35, body mass index is about 35, it is morbidly obese patient. And obesity has got a list of the consequences because it has got many problems ranging from effect of the weight on the body leading to the pulmonary problems, hypertension, diabetes, and etc. So obesity is one of the high risk group to be indulged or develop complications during anesthesia. Then emergency anesthesia. In emergency, patient may come across for various reasons, from minor surgery like hernia, like fracture of the femur or fracture of the humerus, or it may come for the major surgery like obstruction, or there may be multi-polytrauma, road traffic accident, or firearm injury. So it depends. The difference between emergency and routine anesthesia is very simple. In the routine, your patient is stabilized, optimized prior to induce the anesthesia. While in emergency, you do not have enough time to prepare that patient for anesthesia and surgery. And meanwhile, your patient may be suffering from comorbid diseases, maybe very simple disease like controlled hypertension, controlled diabetes, or maybe uncontrolled things, uncontrolled hypertension, diabetes, chronic kidney disease, ischemic disease, heart failure, whatsoever, the list of the problems patient may have. So you do not have enough time to optimize that patient, so the risk of the complication is high in emergency surgery. And obstetric anesthesia, again, it may come in the emergency as well as the non-emergency. The peculiarity of this is obstetric patient, there is changes in the physiology, maternal physiology. These changes affect all the body systems, and the effect of that is also problematic and may produce complication during anesthesia. Then the age, extremes of the ages. Extremes of the ages means age, it may be the elderly means above 60 years of age, maybe up to 100 years of age, or it may be premature neonate and neonate. So extremes of the ages, there is a lot of physiological, pharmacological, anatomical changes occurring in extreme of the ages. Like if you are dealing with a premature neonate, then prematurity is again defined as mild, moderate, and severe prematurity. And extreme prematurity, there is very low birth weight, and patient's body systems are not developed, and he or she is unable to tolerate even normal stresses. So the extremes of ages are associated with high incidence of complication during anesthesia. So most common complication, if we label and we come across, is arrhythmias. Arrhythmia means rhythm other than the sinus. It may be bradycardia, it may be tachycardia, it may be supraventricular arrhythmias, it may be ventricular tachycardia, and or it may end up into lethal rhythms like ventricular fibrillation, and patient may go to cardiac arrest. So arrhythmias, never think arrhythmias are innocent. Always, if your patient has developed the arrhythmias during anesthesia, take it seriously, sort out the cause, and have solution and treat promptly. And there is hypotension. Most of the time there is hypertension during surgery if your anesthesia is unbalanced or not balanced. But hypotension is very much detrimental. You need to prevent, identify, and treat these promptly. And there are certain drug reactions. Anesthesia is a versatile field in a way that you give or inject 5 to 10 drugs within 3 to 5 minutes during induction. So it's the very different from other fields, because you are going to inject lot of the drugs, different agents in a very short duration of the time. So there may be mild reaction to severe reaction, and there may be hypersensitivity to anaphylactic to anaphylactoid drug reactions. So you need to identify, treat as well as these conditions, because you need to be very much vigilant, and to prevent these interactions or to prevent these reactions, you need to give drugs very casually, slowly, and carefully. Obviously, once we anesthetize patient, it's prime responsibility and job of the anesthesiologist to maintain airway and ventilation of the patient. And adequacy of the ventilation is a very big responsibility upon anesthesia or anesthetist. You are going to give the drugs which are CNS depressant, neuromuscular junction blockers, sedatives, hypnotics. So for that, you need to have adequately managed airway of the patient and then proper ventilation of the patient. So sometimes your patient may develop inadequate ventilation, and inadequate ventilation will lead primarily to two things, that is hypercarbia and hypoxia. And once there is hypercarbia and hypoxia, your patient initially may represent with arrhythmia, decreased saturation, and may end up into the cardiac arrest. So this area is a very carefully managed, is to be managed carefully, identified and treat promptly. Here you do not have hours, you do not have minutes, it's game of the seconds. If your patient is not being ventilated properly and hypoxia develops, it may cause permanent brain damage of the patient. So we need to be very much careful during anesthesia. What is the outcome of complication? As I told in the introduction, that there may be morbidity, may be anesthesia-related mortality, means death. So you need to have prevent cardiac arrest if it's impending. And I told, if the hypoxia is not treated within the adequate time, then your patient may develop permanent neurological damage. And that is very much detrimental for the patient, for the caregivers, for the family, and for the society. That if your patient is in a vegetative state and he needs now few person to look after him throughout his or her life. So always be careful while managing ventilation, oxygenation of the patient. Why do these complications occurs? Obviously, we all are the humans, and our technician, we doctors, our other staff may do some error. There may be some error in the drugs, there may be some error in the labeling of the drugs, there may be errors in identification of the drugs. You may want to give one drug, by error you may inject another one, or your assistant is making that drug and he's labeling a wrong way. So there are a lot of the factors which lead to human error. So you need to be very much vigilant to avoid these human errors. Another source is poor monitoring. Anesthesia is a very much vigilant, anesthetist must be very much vigilant, because monitoring has a very essential pivotal role in proper management of the patient during surgery and anesthesia, and outcome depends upon that. If your anesthetist is throughout the conduct of the anesthesia and surgery available with you, it's called as standard 1 of monitoring. And the standard 2 of monitoring is the monitoring of the patient. There is clinical monitoring and monitoring through equipment, monitoring of the oxygenation, monitoring of the ventilation, monitoring of the circulation, and monitoring of the temperature. These are the 4 things which comes in the standard 2. So for standard 1, anesthetist and this clinical monitor is very much important. Then there are certain errors and malfunctions. Your patient is on the mechanical ventilator during surgery, but is functioning improperly, and you don't know you are going to intubate the patient, but your laryngoscope is not working. Your electricity source is not working. So it may lead to problems. So, and finally, the organization failure. Organization failure is a very much important and broad term. Organization failure means the step which you are going on step A, we are going to do on the step A, you are going to do on the step A, you are doing that on the C. The step which you are going to do on the step D, you are going to do on step A. For example, let me give example of basic life support. In BLS, what we do is circulation and airway and breathing. So what you do, CAB, circulation, airway, breathing. Previously we were doing ABC, airway, breathing, circulation. So by the experience throughout the world, they came to know if your patient is in the cardiac arrest. First, if you are going to institute adequate circulation by adequate chest pump, and then your patient's outcome will be better. So organization of the steps of the management are very much important. And if your organization is good, your patients are to be managed properly, and the chances of the complications are rare. And obviously, how can we prevent these complications? These are through, as I told earlier, that constant vigilance, appropriate monitoring. Monitoring is both clinically, you are going to see the patient, you are going to do the site of the surgery, you are going to have an eye upon the surgeon, what he is doing, at what step of surgery he is, and again the monitoring through instruments like pulse oximetry, capnography, non-invasive blood pressure monitoring and temperature monitoring. So monitoring is a very much important towards preventing, and above all is effective and well rehearsed plan of action. There are certain conditions which occur rarely, like you may have heard the word malignant hyperthermia, and out of your batch of 250, I don't think any one of them you may have come across that patient throughout their life, and maybe in your future career you may come across that patient. I have 22 years experience in my field. I gone through only 2 patients of that condition, that is malignant hyperthermia. So these are rare conditions, so for which you have rehearsal simulation sessions to be every 6 monthly. Your team must go through the simulation that if your patient, by making a scenario, if your patient is developing this problem, then you are going to face, your plan of the action, you will be in this direction. But it's for the simple things. If your patient is developing hypoxia, what should be your drill? If your patient is going to develop tachycardia, what should be your steps of management? If your patient is going to develop bradycardia, what your steps should be? What your steps should be for his management? If your patient is developing hypotension, how you are going to manage? Like if your patient doing hypotension during anesthesia, see that your patient is more depth of the anesthesia, make some lighter. If your patient needs fluid, give the fluids, crystalloids, colloids. Then if your patient is not being managed by that, then you are going to add vasopressors, inotrops. These must be readily available and prepared prior to surgery. So effective and well-rehearsed plan of action prevents a lot of the complication apart from constant vigilance, then appropriate monitoring, then effective and well-rehearsed plan of the action. Now we are touching system-wise, that what complication, what very common complication we may come across during surgery and anesthesia, and what are the very brief reasons and way of treatment of these. In cardiovascular system, as I told you, in arrhythmias, your patient may develop bradycardia, tachycardia, bradycardia. Maybe patient is athlete, young, maybe there is vagal stimulation during surgery, maybe you are using some drugs which are doing that, so you need to sort out, prevent and treat the card. Same cases for the tachycardia. Tachycardia is the most commonest condition during every anesthesia, because you are going to manipulate airway of the patient, because you are going to give incision, provide pain. So tachycardia occurs, but it should be within the limits. If it's not treated or identified properly, you need to give proper analgesics. They need to raise depth of anesthesia and identify other causes like ischemia during anesthesia, hypoglycemia during anesthesia. So you need to be very much particular. In arrhythmias, there may be PVCs, that is premature ventricular contractions. And premature ventricular contraction may occur because of hypoxia, because of hypercarbia, or there is electrical imbalance, or your patient is having already ischemic heart disease. So need to identify that, because PVCs may turn into the ventricular tachycardia, and ventricular tachycardia maybe end up into the lethal rhythm, that is ventricular fibrillation. Then hypo or hypertension. If these are occurring during anesthesia, there is certain definition of these things. Your patient's blood pressure, if it is 25% below the preoperative status after the induction of the anesthesia, thereafter you are going to label that it's the hypotension during anesthesia. As I told, you need to give fluid, vasopressors, etc. In hypertension, again, same, if your blood pressure is above 25% of the baseline or pre-induction time, then you are going to treat or address that condition by deepening anesthesia, giving more analgesic, sedatives, and obviously there may be some surgical reasons. There are certain surgeries where there is hypertension, like you are managing renal surgery, there is stimulation of suprarenal glands and release of catecholamines, or there are certain conditions like pheochromocytoma, or your patient having developing conditions like thyroid storm, or your patient is having malignant hypothermia. So you need to identify and treat that condition. And myocardial ischemia is very difficult and versatile. If your patient is developing myocardial ischemia during anesthesia, your patient may present with sudden unexplained hypotension. Be carefully, retain my words. If your patient is developing sudden unexplained hypotension during anesthesia, always suspect that he is developing myocardial ischemia. If a patient is prone to that, like his age is above 40, or he is having diabetes, he is having hypertension, etc. And there may be certain conditions like embolism. Embolism is a condition which is occurring into like fat embolism, amniotic fluid embolism, or your patient is suffering from deep vein thromboembolism, DVT, so it may go up to the thromboembolism. So there are certain identifications like hypotension during anesthesia, and you need to, and if the patient is having a risk of that, you need to identify the treat. And the cardiac arrest is a very lethal thing. Cardiac arrest means cessation of pumping activity of the heart. It's the loss and very lethal complication if we take in the severe cardiovascular system. So your patient need cardiopulmonary resuscitation. We are going to touch the respiratory system. Hypoxia. Our teachers, our books says the complication during anesthesia never ever kill the patient until unless you identify and treat promptly. The hypoxemia is one of them. If it is not going to kill your patient, it may make your patient permanently disabled, and also dependent upon the family. So you need to be very much careful while you are managing your patient. So hypoxia may occur during surgery, hypoxia may occur after surgery, hypoxia may be multiple reasons, from oxygen supply system to failure in the anesthesia machine. There may be disconnections of the circuits. There may be a problem in the patient's airway. There may be problem in the patient's lungs. There may be problem in the blood, that is anemia, or there may be some poisonings. So you need to, there may be some severe infection. So need to treat, identify hypoxia. And hypocapnia and hypercapnia, again, if you are ventilating too high with high tidal volumes, high respiratory rate, your patient may develop reduced carbon dioxide concentration, and again it may develop PVCs, and your patient may end up into delayed recovery. If your patient is developing hypoventilation, it may retain carbon dioxide. It may again causes hypertension, tachycardia, and your patient may end up into the lethal rhythms, as well as there may be the acidosis to the patient. Then the obstruction, respiratory obstruction, it's a term in which you are going to manage the airway of the patient. While you are managing the airway, we use the Godel airway, we use endotracheal tube, we use supraglottic devices, laryngeal mass airway. When you will visit our unit or operation theater, all of these gadgets, you will observe yourself and see these things. So there may be obstruction even simply by you sedated the patient's tongue falls, and there is blockage of passage, and your patient may lead to obstruction. So need to relieve obstruction and also treat the cause. And the pneumothorax is a very lethal complication if it occurs during surgery. This is the thing which you need to identify, because pneumothorax may be heterogenic, may be spontaneous, and may be because of trauma. So heterogenic means during surgery, if your anesthetist is performing central lines, putting central lines, or there is any reason in the airway management, your patient may develop pneumothorax, and it may be a simple pneumothorax or it may be the tension pneumothorax. If it's the tension pneumothorax, then situation is worse. It needs prompt relief. For the sake of that, you need to put initially a 14 gauge cannula in second intercostal step in the mid-memory line. Just to relieve that problem, then you need to pass the endotracheal chest intubation in that patient. So you need to identify pneumothorax, because it may present with hypoxia, it may present with the shifting of the mediastinum, and there are certain problems of the endotracheal intubation. Endotracheal intubation is simply looks like a very simple job. But in certain situation, there are multiple factors related to the patient, related to the equipment, related to anesthetist. Sometimes you are unable to pass endotracheal tube through these structure larynx. Then this may go into the problem. It's not only the intubation problem, but if you are failed to intubate your patient, then your patient may develop hypoxia, and you need to have certain remedies for that. Now, another important thing is aspiration of the gastric contents. Aspiration is a lethal complication. Aspiration of the gastric contents occurs if you in certain vulnerable patient. As we in the beginning, I said the emergency anesthesia is associated with a lot of the complications. So emergency anesthesia, your patient is full stomach. 2 hours before incident, accident, gunshot, your patient has taken food, and now your patient is full stomach. And when you are going to anesthetize the patient, there are risks of regurgitation, then aspiration of this content into the lungs. And it's a very, very dangerous complication. But it depends what is aspirated, how much is aspirated, and what was the pH of aspirant fluid. So your patient may develop Mendelssohn syndrome. If pH is very low, stomach acidic secretion, and volume is more than 2.4 mils, volume is more than 0.5 mils per kg of the patient. It is aspirated through the lungs. It may cause chemical damage or pneumonitis of the patient. So need to prevent. This is the problem which occurs in the routine obstetric surgery as well, because progesterone causes excessive release, causes excessive delayed emptying of the stomach, and gravid uterus pushes the stomach upwards. So during routine surgery and induction of anesthesia, there are chances of risk of regurgitation and aspiration. So you need to be careful. For that reason, in obstetrics, regional means spinal and epidural are preferred, because they are associated with less complication as compared to general anesthesia. There may be central nervous system problems like ischemia of CNS. If your patient is hypoxic, there may be ischemia. We have talked a lot about the hypoxia. It may cause ischemia, but there is another term, awareness. Awareness is a very important and irritating complication that is appeared after your patient is out of anesthesia. Because awareness occurs during general anesthesia. Awareness means your patient, when it's out of the anesthesia, he or she recalls the events of that surgery. or anesthesia. So this awareness must be prevented, and if it occurs, it must be admitted, and patient may behave restlessly, irritably in post-operative period. So you need to be very much careful for this during anesthesia. Another monitor is applied on the forehead that is called as BIS monitor, bispectral index monitor, which monitors depth of the anesthesia. So you need to have that one or other tools. So you need to have your patient deep while you are anesthetized. There are certain surgeries like cardiac surgery, recovery phase of the cardiac surgery, or induction phase of the obstetric anesthesia, where you are going to give very low doses of sedative, hypnotics, or opioid agents. So there are the risk surgical regions where your patient may end up into the awareness during anesthesia. So, but on other surgeries, there is no excuse that your patient remained aware during anesthesia. It's a crime, and anesthetist must be responsible for that prevention of the awareness. We talk about the drug reactions, hypersensitivity, idiosyncrasies, as well as drug interaction. As I told, we use 10 drugs in 5 minutes. So obviously there may be some interaction. We need to be careful and meticulous attention. If anything is occurring, we must be identifying properly and treating within no time. There are injuries. There is a list of injuries. Injury may occur during positioning. For prolonged surgeries, your patient is positioned in some position. There is obviously pressure on the soft tissue, pressure on the nerves, pressure on the eyeball, pressure on the ear, pressure on every area of the body. So there may occur in the injuries. You need to have remedies of prevention of this. So there are positions associated with the injuries, lithotomy position, other position. But the dental is important. Dental injury occurs when we are going to intubate the patient, when we pass the endotracheal tube with a hard instrument that is called laryngoscope blade. If the patient's dentures are loose or there are buck teeth, your patient may end up in the damage of the dental, and it's very much common. There may be injury to the eye, injury to the cornea, as well as there may be certain burns. Burn injury occurs when it's mostly occurring from the surgical side. Diathermy pellets they put, and they use diathermy. If not properly wrapped with the towel, or it's not properly humidified or liquidified, then their patient may develop the burn. And then electrical injuries. I will divide it into the two. There is static electricity that is generated during anesthesia, as well as these routine electricity. So you need to be careful because you are using certain instruments, you are using certain things. Obviously, they are electricity driven. So you need to be very much careful for that. Then there may be problem in the equipments, as well as equipments which we use is for the monitoring equipments. Equipment we use for the airway management. These both we discussed. Third equipment written is tourniquet. I will touch a little bit upon the tourniquet. Tourniquets are applied to occlude supply of that particular area. There may be rubber tourniquets, then there may be pneumatic tourniquets. The good ones are the pneumatic tourniquets. And the tourniquets may be double cuffed, may be single cuffed. So we in anesthesia use tourniquet for blocking the limbs, that is intravenous regional anesthesia. And in that we put this on the upper arm, and then we inject that limb with the drug, and almost 40-50 ml of the drug we use. If accidentally that tourniquet deflated during this procedure, all the anesthetic will go into the central circulation, and it will cause cardiovascular and CNS problems. So tourniquets are to be used carefully as well as monitored carefully, and may end up into the problem. Or tourniquet is inflated, surgery is performed, 1 hour passed, you forget to deflate the tourniquet, and your patient may end up into the ischemia of that limb or that area. So tourniquet must be used carefully during anesthesia and surgery. In the earlier, I told you the hypothermia may occur in the prolonged surgeries, but hyperthermia may also occur. That again I told you in the malignant hyperthermia, or ordinarily there may be temperature because of the your patient is having an infection or sepsis. Malignant hyperthermia is a very lethal condition. It's a very separate topic, needs at least 1 hour. So you go and see on the internet, Google or the books what it is and how it is identified and managed. But I tell you, the malignant hyperthermia occurs in a certain susceptible patients where there is a problem in the gene ryanodine receptors, and that patient responds by excessive metabolic reaction to the drugs. Only 2 groups of the anesthetics that are in all the inhalation agents may trigger malignant hyperthermia and depolarizing muscle relaxants. So these you need to go through this. But hypothermia, every anesthesia, irrespective of the duration, it goes to the hypothermia. So anesthetists need to prevent hypothermia or manage hypothermia, because hypothermia has lot of consequences. For example, I can say it causes the hypercoagulability, it causes arrhythmias, it causes delayed recovery during surgery, it causes coagulation problems, so it causes many other things, delayed wound healing, etc. So you need to identify, you need to monitor temperature. If it is getting down, then you need to warm the atmosphere as well as give the warm fluid and take and sort out the remedies to treat this hypothermia, because it may cause arrhythmias as well. Then there are miscellaneous complications, like your patient for any reason, noise pollution or any something else, or because of any drug, it may end up into hearing loss. There are other things, that is latex allergy. The equipment we use, like a mask, like laryngeal mask, airways, and other things. These, even the gloves, these are made up of the latex. And few percent, some population is allergic with that rubber material that is called as latex. So this is to be identified. If it occurs, it again treated like we use to treat certain reactions. Then radiation exposure, it is not in routine surgery. It may occur in different areas, different type of the surgeries, different type of the environment, but it may occur, and we need to identify, prevent, and treat our patient. Now we are shifting to the regional anesthesia. The complication we discussed before this, these were associated with general anesthesia, but these all may occur during regional anesthesia. Here we will touch upon separate complication that will not occur during general anesthesia, but the complication may occur in general anesthesia that may occur during regional anesthesia. So apart from the complication we discussed up till now, there are certain different complications which may occur in addition to the complication occurring during general anesthesia. These are procedure relevant, diet, like inability to reach subarachnoid state because of anatomy or position. As I discussed with you, obesity. In obesity, your routine instrument even cannot reach up to the dura, your subarachnoid space. So you need special needles and equipments and gadgets, extra long size to reach there. Your patient, you put the needle, CSF is coming out from the needle, you injected the drug, but it's not working. There may be technical reason, there may be septum in the drug you went on some different path, or your needle is little bit vibrated during injection, and you lost that space where you intended to inject that drug. There may be damage of the needle, spinal needle, or needle may be left inside the space. It may cause foreign body formation. So these are the things which may occur. And same cardiovascular hypotension, cardiac arrhythmia, cardiac arrest, these may occur during spinal anesthesia, and respiratory problems, inadequate ventilation, secondary motor blockade. This is something in addition to already discussed complication. If your patient is developing high motor blockade, then it will take time, because if your intercostal muscles, abdominal muscles are paralyzed, then it will be difficult for the patient. It will just keep on pumping respiration just through diaphragm, because intercostal and abdominal muscle are lost. So there will be inadequacy of the ventilation and oxygenation. You need to take care of that patient, but if occurs, it's all the reversible. The beauty of this complication is that it's reversible. You need to support oxygenation, ventilation till the time of the block is faded, block is lost, then all will recover spontaneously. Then total spinal anesthesia is a complication occurring during epidural anesthesia. In regional anesthesia, there is a local infiltration of local anesthetic, put the local anesthetic on any tissue. There is blockage of certain plexus, like brachial plexus, cervical plexus, lumbar plexus, or you are going to block the mid-axial blockage. In that, you need to put a spinal anesthesia that is called a subarachnoid block, or before that there is a space that is epidural space. You need to put drug there. When you are using the epidural space, difference is that you need lot of volumes of the drug to achieve that block. And when you are going to inject that volume and your needle accidentally slips in subarachnoid space, then drug will ascend and there will be total blockage. Or if your patient, you are injecting lot of volume, during injection, your needle slips into any vein, there will be intravascular injection of local anesthetic and will cause problems or complications. In regional anesthesia, there is impaired thermoregulation. Patient may shiver and exhibit hyperthermia. Once your patient is shivering, obviously it is generating heat. Body is moving, muscles are twitching, heat is generated. So in shivering, there is hyperthermia. But shivering must be treated. And interestingly, there is no proper treatment of the shivering during and after anesthesia. Shivering occurs spontaneously, resolves spontaneously. There is no any reason behind that. There is no any treatment. But there are certain remedies. You need to elevate the temperature of that space. You need to stop the drug or drip or fluid which was used. Maybe pyrogens are in that, and these are causing shivering. You need to remove that from another fresh one. And then you need to give tramadol. That is the drug which causes a very beautiful effect on the shivering. But there is no proven scientific reason that how it works and how the patient is prevented from the shivering. As I told you, local anesthetic toxicity, it occurs from intravascular injection or even in the different areas where you injected large volume. Obviously, in every area there is absorption of the drug. It is absorbed in the larger volumes, larger quantities. It will circulate in the circulation and causes cardiovascular respiratory problems and CNS problems. And then nausea and vomiting. Nausea and vomiting is a very, very distressing complication. Vomiting once occur, patient gets relieved. And patient sometimes says, sort out that I am nauseating, it's better I should vomit. And once I would vomit, then I would get relief. But nausea is throughout irritating. Again, it is associated with multi-factor, patient factor related to the patient, factor related to the position, factor related to the drugs. So beautiful treatment of nausea vomiting is prevention, prevention, prevention. For that prevention, you give drugs prior to induction of anesthesia, in which you need to give gastroprokinetic, you need to give 5-HT antagonists, and these are the drugs ondansetron in combination with dexamethasone. So most useful take-home message for prevention of nausea vomiting is the combination of dexamethasone and ondansetron or granisetron. That group of drug it will prevent. Pruritus, the complication associated with the opioids. So it may occur, but these are the rare conditions. Then inadequate block, that is failure. You given the drug, you put drug in the proper space, but you didn't got the result. And the patient is still in pain, patient is limb is moving, then it's useless. That is also failure of that technique. I will touch a very few complications in early postoperative period. And one devastating, disturbing complication is PDPH, post-dural puncture headache. If you put spinal or epidural, in spinal you pierce the dura, in epidural if you accidentally pierce the dura, your patient may develop post-dural puncture headache. It's very easy to diagnose that condition. It occurs after 6 hours to even weeks after anesthesia. After 6 hours to weeks after anesthesia, and how it manifests, you or your patient gets headache while sitting or walking and relieves on lying down. It's a very simple. First, it's a history of spinal or epidural anesthesia, and then if it is developed and it is aggravating when you sit or you walk, and it relieves when your patient is lying down. It has very simple remedies, means treatment, like your patient needs lot of fluids, plenty of hydration, fluids, stool softeners, and caffeine is a coffee or caffeine is a drug of choice in these patients. And sometimes your patient needs certain invasive things like epidural blood patch. It's a different big topic, how it occurs, which patients are vulnerable for this condition, and how it's treated. It's a separate topic. Urinary retention is a very common because of the effect of the in a local anesthetic and urinary blockage, but it's transient. Means if you are putting catheter to your patient for 6-8 hours, thereafter the effect of the block are weaned off or fed, your patient have normal micturition reflex, and it gets better. There are neurological complications during regional anesthesia, direct, indirect injury while you are putting drug injection into the neurological cell block or through certain plexus block. This may be transient or permanent injury. Your patient may develop cauda equina syndrome, means that is bladder and bowel dysfunction. That may be permanent, that may be transient. But there are also transient neurological symptoms that again mimics same like bladder bowel dysfunction and other things. But again, as word denotes, these are transient, no treatment is needed, and your patient gets better. If your patient you didn't perform hygienic block, your patient may develop epidural abscess, your patient may develop epidural hematoma. If your patient is developing epidural hematoma, it will develop earlier during procedure, but it occurs in patient who is taking anticoagulant drug, who is taking warfarin, heparin, or who the patient is having liver disease or renal dysfunction where there is platelet and coagulation factor deficiency. So you need to avoid regional anesthesia in these patients, because epidural hematoma is a medical emergency. If it occurs, it would paralyze your patient. If the hematoma is not relieved within 4 to 6 hours, your patient may end up into permanent paraplegia. While epidural abscess, it takes times because there are organisms, microorganisms, and which keep on accumulating. Then abscess goes on aggravating. Then abscess becomes from small to large. It may produce local features as well as systemic infection features. It needs the treatment. Sometimes incision drainage and as well as broad spectrum antibiotic. But if your patient is developing hematoma, it's an emergency. You need to treat that promptly. Then there may be generalized infection. There may be back pain. It's a myth. I have 22 years experience in my field. Why every time when I put a spinal, patient says it will produce backache, it will continue throughout our life. So it's a myth. It's not the reality. There is no any backache, any high incidence of backache associated with spinal epidural anesthesia. We used to put these 6 to 7 times. Last evening, I was putting spinal to a lady. She was being operated for fifth time, fifth cesarean section. There's no thing like backache associated with spinal epidural, but there is some degree of this may occur. So it is even more in general anesthesia in awkward position, lithotomy position, surgery in different position. There may be chances of backache more than to the needle injury. So it's not a big problem. And then there may be certain unusual complication. As I told you, hearing loss is unusual complication. Swallowing difficulties, again, unusual complication. So swallowing difficulties may occur, hearing loss may occur, and Horner syndrome may occur. And Horner syndrome is a complication. You can count it as a complication as well as if you can count Horner syndrome as an indication of successful block. If you are putting blocks in brachial plexus block is through interscalene approach, supraclavicular approach, infraclavicular approach, axillary approach. If you block that in interscalene route, then that local anesthetic may cause multiple problems, including Horner syndrome. And Horner syndrome is what? It is development of meiosis, anhidrosis, ptosis, and also dryness of the secretions of nose, as well as loss of lacrimation of same eye. Meiosis, anhidrosis, dryness of secretions of nose, as well as loss of lacrimation of same side of eye. That is called as Horner syndrome. It's complication. But in chronic pain management conditions, when there is pain occurring from the upper limb or areas of the shoulder, upper limb or the neck, and pain is sympathetically mediated, that is called reflex sympathetic dystrophy, casualties. These are the way, or any ischemia of the limb, Raynaud's disease. These are treated by blocking stellate ganglia. And stellate ganglia is a ganglia from cervical as well upper limb sympathetic chain. So we intentionally block that stellate ganglia to prevent pain or treat pain occurring from the upper limb. So in which once we are blocking and putting the drug, and if patient develops Horner syndrome, we as a pain physician are happy that drug is on the proper site and your patient gets relief. Thank you very much. I am here for the questions, answers, and I will be happy because it's a very big topic, and every area of this topic needs separate lecture. Since we do not have enough time, so we may discuss these in the while you are in ward posting, or while you are coming with us for house job or ward posting, and hopefully the you are coming back from after 15th September, and then the things will become normal after this COVID, and we used to have these physical in-person classes rather than virtual online classes. Thank you very much. So any question? Open hand. Yes, beta, any question if you want to ask? Anything which you want to comment, anything which you want to suggest, any problem you have in online classes, since I am in administration as well. So if we are going to have any message from your side and we can solve that problem, I am here. It's okay, and then enjoy the weather if you rain at your area where you live. Any question you want to have, I am still available. If you are not hearing me,
Sir, can you hear me?
yes, yes. It's okay. Have a good day and go and see what is PDPH, and I told another thing, what is malignant hyperthermia. Google it, use the book and go through that. These are important. And lastly, I told you interesting thing, that is Horner syndrome is complication as well as the indication of successful block. Stellate ganglion block, also go through this. And always remember that avoid hypoxia during anesthesia, because hypoxia will lead to major damage, as may lead to permanent mental illness, and that will be very detrimental for the patient and family. Thank you very much.